So good afternoon, everyone. Thanks for coming to our neurology case conference. We have 3 cases for this week. The case number 1 is, she's a 26-year-old female presented with 2 months history of headache. The headache is associated with dizziness and ringing sensation in her ear. The symptoms are ongoing for the past 2 months, and the headache is occur on daily basis and doesn't resolve with any medications. And she has a history of chronic migraine headache, which occurs 1 to 2 per month, which usually lasts for a couple of hours, resolve with NSAID. And the character of the headache is predominantly over the frontal region. She described this pain as a sharp pain on the scale of 8 out of 10, associated with the photophobia. Coughing, sneezing, bending her head makes the headache worse. Rest makes the headache better. So based upon the history, it tells us there is something concerning for increase intracranial pressure, because she's bending her head, and coughing, sneezing makes the headache worse. Past medical history is Ehlers-Danlos syndrome, fibromyalgia, endometriosis, polycystic ovarian disease, and hypothyroidism, and recent weight gain of 40 pounds over the past 2 years. And past medical history is history of tonsillectomy, foot surgery, hip surgery, and tooth extraction. Social drinker, but otherwise denies smoking and recreational drugs. Vitals are pretty stable. So given the history of increase in intracranial pressure, we decided to get an MRI brain and MRI of the C-spine also. And she does complain of mild numbness in the bilateral upper extremities.
Hey guys, I'm Dr. Porter. I'm one of the radiologists here, and I was going to review some of the imaging pertinent to discussion. So let's see. Is this I just first want to make sure I pulled up the correct patient. This 36-year-old. Is this the different? Okay. Let's start with the correct patient. So this patient has a lumbar puncture with an opening pressure of 20.
Yeah. So the other one is, the image goes for the other patient.
Okay. Let's see, maybe this one.
Yeah.
So MRI imaging was performed of the cervical spine, the brain, and the orbits. So just a point of discussion, so the brain, routine brain MRI does include some orbital imaging, but if orbital pathology specifically involving the globe or the intraorbital optic nerves is on the differential, then a separate dedicated orbital MRI should be ordered in those scenarios. But on review of the MRI of the cervical spine, 25-year-old female. It's essentially normal, good alignment, spinal cord, normal signal intensity, and contour without abnormality in the cervical spinal cord. So pretty good cervical spine MRI. And then look at the brain MRI and look at the sagittal. This is a post-contrast sequence, but we're looking at a sagittal reconstructed view of the brain at the midline. So here we have corpus callosum, thalamus, tectum, midbrain, mammillary bodies. This is the pituitary infundibulum. And these are the optic nerves. This is the sella with the pituitary gland here along the floor of the sella. So usually, especially in younger patients, the pituitary gland measures around 10 millimeters in the craniocaudal dimension and usually has like a more rounded shape with a superior convexity. Here we see some kind of concave margin of the superior aspect of the pituitary gland, and it looks like it's kind of getting flattened along the floor of the osseous sella. There's not really much in the way of cerebellar tonsillar ectopia, and the ventricular size and configuration looks within normal limits for age. So I'll kind of come back to those points in just a second. But when we look at the dedicated orbital MRI sequences, this is now a coronal reconstruction in the T2 weighted sequence. So kind of here we are at the level of the optic chiasm. And this is the pituitary gland again, now in the coronal section. And as we come anteriorly, these are the prechiasmatic optic nerves going into the osseous optic canals, and then they're entering the orbits here. So this, the center of the donut here is the nerve itself, and the white ring around it is the optic nerve sheath. And usually the optic nerve sheath is closely opposed to the nerve. So these are distended optic nerve sheaths. And then probably on the axial sequence of the dedicated orbital, you can probably better appreciate there's usually the optic nerves have a pretty straight course through the orbit. These are kind of tortuous and also associated with flattening of the posterior sclera. So usually the globes have a very symmetric spherical shape. And in this case, you can see basically the imaging manifestations of papilledema. You've got CSF distending the optic nerve sheath, and then the pressure is high enough that it's actually bulging the posterior sclera at the level of the optic disc. So this is, you do a fundoscopic exam, see the same from the external to internal, and this is kind of the MR imaging appearance of papilledema. So that would be concordant with elevated intracranial pressure. And just kind of while we still have the MRI pulled up, some other kind of common findings for increased intracranial pressure on MRI would be slit-like ventricles, cerebellar tonsillar ectopia. This is probably very mild empty sella. A lot of cases, the pituitary gland will be almost undetectable because it's so flattened against the sella, and the sella can really enlarge and become a very bulbous osseous lesion kind of extending into the adjacent sphenoid sinus. And then that same regard, there's a lot of other documented findings of osseous remodeling just secondary to the increased intracranial pressure. One that's been commonly reported is Meckel's cave meningoceles. So Meckel's cave is where the trigeminal ganglion is. So like this is the right Meckel's cave. This is the left Meckel's cave. And similar to how the optic nerve sheaths of the dilate in the orbits, this area can dilate with a CSF space. And I've also seen some cases of geniculate ganglion meningoceles where the facial nerve is traveling in the temporal bone. So we're dealing with a very high pressure system, enough that it's actually remodeling bone and dilating CSF spaces in an abnormal manner. But this patient does have manifestations of partially empty sella and papilledema, both of which point towards increased intracranial pressure.
So papilledema is a clinical diagnosis. You have to rule out all other possibilities. Other possibilities like venous sinus thrombosis, the venous is completely patent over in our patient, and also mass lesions, and which we did not see on the imaging. So with the provisional diagnosis of IAH, we went and did a LP. LP showed an opening pressure of 44, which is way higher for her age. And she was started with the Diamox of like 250 twice a day for 4 days, and then like plan is to increase it to 500 twice a day in a week time. And also prior coming to our hospital, she was evaluated by ophthalmology, and ophthalmology reported us like grade 2 on the right and grade 3 papilledema on the left. So just a little bit about IAH. IAH is also otherwise called as like pseudotumor cerebri. It's due to increased intracranial pressure associated with the headache, papilledema, vision changes, or pulsatile tinnitus, which all the findings she had it actually in the setting of normal imaging and CSF studies. And most commonly affecting females with age group of 20 to 44. Annual incidences like 20 per 100,000, which weighs like, it's more commonly seen in with patients with high BMI. Clinical presentation was like headache often daily, sometimes associated with the severity in the morning, and also with Valsalva. And associated symptoms like nausea, vomiting, photophobia, neck pain, and back pain. And they may have like a transient vision loss. It can be monocular or binocular, can be partial or complete. And diplopia is very common due to increased intracranial pressure, where it can give a pressure on the abducens nerve. You'll see more of double vision, and binocular diplopia and horizontal diplopia also. Pulsatile tinnitus is more common due to increased intracranial pressure. Often can be like bilateral, but can also seen in unilateral also. If it is untreated, up to like 30% of the patients can lose the vision over the period of time. Physical exam findings, you'll see papilledema on the with the fundoscopy, and you'll see like cranial nerve, 6 palsy, lateral rectus palsy, visual field deficits. Diagnostic workup wise like MRI and MRV to rule out any venous sinus thrombosis or any mass lesions. LP with opening pressure, and they require like serial ophthalmological evaluation upon the discharge, and they may have to adjust the medication based upon the papilledema finding on the imaging. Treatment wise, like they can do like a diagnostic lumbar puncture, which would reduce the pressure. Weight loss, it's a significant benefit on those patients. And other things like carbonic anhydrase inhibitor like Diamox, which reduce the CSF production. Topiramate, it's a very good drug, which can be used in this patient, but the drawback is half of these patients on mostly on childbearing age. So we have to be very cautious in using this patient on these patients. Diuretic seems to be effective, but it is not well used on these patients actually. On refractory cases, they can do like optic nerve sheath fenestration, and also they can do VP shunt, which will reduce the CSF pressure. So case number 2, she's a 36-year-old female.
I would just add to the treatment possibilities, more recently, even within the last 2 years, there's been some literature that discusses the tendency for these patients to have the stenosis of the neurovenous sinuses. So if you got a patient with IAH, if you haven't already done a dedicated intracranial venous workup, they needed one to exclude a thrombus and two to evaluate for potential stenosis, and then those patients end up with our neurointerventional radiologists and get some pressure gradient evaluation to determine whether or not the stenosis is hemodynamically significant. And if there is an increase in pressure gradient across the stenosis, then those patients are candidate for neurovenous sinus stenting. So put a stent in the neurovenous sinus, relieve that stenosis, and then add some really good outcomes as far as treatment for these patients. But not every IH patient is going to have a venous stenosis, and not every venous stenosis is going to be IH. But it's kind of a fairly new option to sort out these patients and potential treatment.
I think like Hawk did like 3-4 cases here. Got it. So case number 2, she's a 36-year-old female. History-wise, like she presented as a motor vehicle accident trauma, and approximately 2 weeks prior to this presentation came to our ER and discharged her with a diagnosis of like hemoperitoneum and L1, L2 fracture. And she was doing well, like after discharging to the home. And then she started having more and more abdominal pain, nausea, vomiting, and fever, and was evaluated at Tenova. They thought like it's not infectious cause. They gave her NSAID and recommended to have a primary care follow-up. And after 2 weeks after I had a motor vehicle accident, she presented with a complaint of like headache, unsteady gait, and paresthesias in the extremities and urinary incontinence. For higher level of care, they transfer her here for further management. So past medical history-wise, like depression and anxiety, and she had a C-section and ACL tear. Vitals are stable, and positive neurological exam finding was like asymmetric weakness in the lower extremities, right greater than left, and she had a sensory level at the level of T6. Means like she has loss of sensation below the level of T6 for pinprick and light touch. So with the these findings are highly supportive of like spinal cord injury, because if it is a peripheral nerve injury, you won't see a sensory level. That's one way of differentiating spinal cord injury from a peripheral nerve injury. And also she has a prior recent history of L1, L2 trauma, which goes well with the supportive of like spinal cord injury. So we went and did a MRI of the T-spine and L-spine first, which Dr. Porter will review the images with us.
So, I think I'm focused on- Yeah.
So de-acceleration.
Yeah, so this is a sagittal stir sequence through the cervical spine, and the stir is just an acronym. Basically, it's a T2 weighted imaging with some fat saturation, but we can kind of make some adjustments in the technical parameters, and it helps to increase the conspicuity of intramedullary cord signal abnormalities. So it's normal for patients to have like a small central canal. That's where the CSF is kind of recirculating within the spinal cord centrally. And sometimes you'll see that on a sagittal sequence, and it should not be mistaken for a lesion or a syrinx. Alternatively, there can be what's called Gibbs artifact or ring artifact that can simulate a syrinx. But I want to draw your attention. It's pretty subtle. It doesn't really project as well up there as it does on the computer screen, but there is an intramedullary cord signal abnormality here at the level of C6, and maybe seen to better advantage. So this is like what the normal cord should look like, kind of this darker gray. And then centrally, there's it's brighter. So, intramedullary cord signal, you start thinking about, could this be tumor? Could this be demyelinating disease? Could it be an alternative etiology of myelitis, either infectious, inflammatory, or ischemic? And as we look farther down in the cord, there's multiple similar areas of intramedullary cord signal abnormality involving the thoracic spinal cord. So he does have, or she does have, some multifocal signal changes within the cervical and thoracic cord, all the way down to the level of the conus. So brain imaging was performed just as kind of a complement to the imaging workup for the neuro axis, basically trying to get a better idea of if this patient could have multiple sclerosis accounting for these lesions. And while you can have isolated spinal cord involvement with multiple sclerosis, it's much more common to have concordant brain imaging abnormalities. And this patient doesn't really have much in the way of white matter signal abnormality intracranially. There are a few areas of periventricular signal changes, but not really specific for MS. So this looks like more like what we would expect for a transverse myelitis type picture, maybe more so than a typical MS, even though so usually MS plaques in the cord, they'll be more focal and they won't be as long segment. They usually do not extend beyond the length of a single vertebrae. So when you have longer lesions or more extensive cord involvement, again, that kind of mitigates against MS and would point more towards alternative etiologies of a transverse myelitis.
So with the suspicious of transverse myelitis or like spinal cord pathology, we did a LP. LP showed elevated leukocytosis with a, I think like protein of 145 actually. It's my mistake, sorry. And glucose. Vitamin D level was found to be 10, vitamin B12 was 121, and copper was slightly lower, but it's like almost normal actually. And paraneoplastic and encephalitis panel came back negative, HIV came back negative, and multiple sclerosis panel came back negative, and neuromyelitis optica panel came back negative, anti-MOG antibody came back negative. So you don't have to wait for the treatment options to all the workup come back. As soon as you have a diagnosis of transverse myelitis, if you rule out all other infection, you can treat these patients with a high-dose IV solimedrol. And these antibody panels or the antibody test will determine the long-term treatment course on these patients actually. So this patient be treated with IV solimedrol for 5 days and slight improvement. And also, again, we started with IVIG for another 5 days, had a significant improvement. She went for rehabilitation. Just a little bit about transverse myelitis. It's a very rare, the name itself is a myelitis, it's an inflammation of the myelin. And but other thing is like the name is a misnomer. It says like transverse myelitis. It is maybe partial or complete. And they often present as like a rapidly onset weakness, sensory deficit, often involved with bowel and bladder dysfunction. And it can occur at any level, but it most commonly affects the thoracic region. And men and women are both equally affected. And most common age group is like when they're like 10 to 20s or like 30s to 40s. Women tend to have more affected on this with the transverse myelitis in association with multiple sclerosis. Incidence is like around like 1 to 8 cases per million. Etiology wise, often like idiopathic, like 50% of the time, we won't know what is the cause for this. And it's often it's a monophasic if it is idiopathic. And second cause like infectious causes, systemic inflammation, and multifocal CNS disorders. Post-infectious wise, that's why it's important to rule out the infection like enterovirus, West Nile, HSV, HIV. In HIV, they used to say like WBC count should be like greater than 50. In our case, like HIV is negative actually. And HTLV1 can cause the presentation, Zika virus, neuroborreliosis, Lyme disease, mycoplasma, and syphilis. Multifocal central nervous system diseases like NMO, multiple sclerosis. The transverse myelitis can present as an initial presentation, and often these patients have like a white matter lesion on the brain. Neuromyelitis optica, it's a separate spectrum of disorder, and they may or may not have a white matter changes on the brain, but they can have involvement of spinal cord. ADEM, acute disseminated encephalomyelitis. It is also very common, but very common in kids actually when compared to adult, and often they have like a CNS manifestation. Sarcoidosis on paraneoplastic disorders can do that. Systemic inflammation like spondylitis, antiphospholipid syndrome, Behçet's disease, connective tissue disorder, sarcoidosis, and SLE can do that. Clinical presentation varies depending on the level of the inflammation. At the level of inflammation, you'll have like a lower motor neuron, like level below that, you'll have upper motor neuron signs. And based upon the level of the involvement, you determine the imaging actually. If you have a upper limb involvement, you'll do like both the C and T. And if you have like just lower motor, like you can find out like what is the cause with it, just with the T and L spine. So the interesting about in this case is she never had any symptoms of prior history of prior symptoms like loss of vision or blurry vision, or any fatigability or tiredness, which could lean towards multiple sclerosis or any prior episode of it. And only history we have is like 2 weeks ago, she had a traumatic injury. So when I reviewed it, like there are some case reports reported like, these are all like few case reports. I'm just like putting the names here, who had a spinal cord injury, and then like subsequently they presented with the transverse myelitis. I think like this case is probably this patient had post-traumatic transverse myelitis. So the differential diagnosis is always broad actually. You have to rule out any compressive myelopathy from the disc, herniated disc, or vertebral body compression, abscess, or mass, or spondylitis, and vascular causes like spinal cord stroke, metabolic causes like vitamin B12 deficiency, copper deficiency, vitamin D deficiency. Nutritional causes also come under the same category, neoplasm and radiations. Evaluation is like MRI of the spine, as I said in the earlier, like it's based upon the location of the lesion. And you always almost like want MRI of the brain with and without contrast to rule out any intracranial lesions, and have a CSF findings, CSF with LP with lumbar puncture to rule out infection, and also rule out any inflammatory causes, send for VDRL and oligogonal bands, and IgG index and cytology. Serum aquaporin antibodies for NMO antibodies, NMO-associated antibody syndromes, and anti-MOG auto antibodies, and vitamin B2 level, and ANA, SSA, SSB, syphilis, HIV antibodies, TSH, and viral etiologies. Treatment-wise, high-dose steroids for in the acute setting, and you can do Plex or IVIG. And if you see any viral etiology for the transverse myelitis, you can treat with antiviral agents. So case number 3, he's a very interesting guy, actually. He's a 56-year-old male. Basically, he was referred here for surgical evaluation for hernia. And when he got here, they thought like he's not a candidate for surgical intervention. And while they're doing the workup, he was found to have an STEMI, admitted under cardiology service. And they did a cath, and he was started on an aspirin and Plavix. He complained like over the past 2 months, complaining of like paresthesia and weakness and unsteady gait. And the symptoms are ongoing for the past 2 months. It is like very slow progressive symptoms, has difficulty with combing hair, buttoning shirt, brushing, and feels like he's walking in a jelly. He had like 2 to 3 falls because of the unsteady gait, but denies any like flu-like symptoms or diarrhea preceding the symptoms. or like any medication changes or vaccinations. So if this case presented like within 4 weeks of symptom onset, you call it as an acute. And if it is anywhere between 4 weeks to 12 weeks, or like 4 to 12 weeks, then you call it as subacute. Anything beyond 12 weeks, you call it as a chronic progressive symptoms. And on my exam, he had like approximately like 5 out of 5 strength, but distally, his intraosseous are very weak, around like 4 out of 5 strength in APB and FTI. And in the lower extremities, like his extensor hallucis longus was like 4 out of 5 strength, has a weak dorsiflexion, inversion, and eversion. It is symmetrical. The weakness is symmetrical on both right side and left side. Sensory exam is vibration is absent in the ankle and toe, but reduced in the knee. Pinprick also reduced like a stock and glow pattern in both upper and lower extremity. And tactile sensation is equally intact in all 4 extremities. And the reflexes are absent in ankle and 1+ in the knee and biceps. So based upon this exam finding, the patient has reduced reflexes and symmetrical distal predominant weakness along with the sensory deficits. And these findings are very concerning for possible neuropathy. And it's unlikely to be myopathy because you have absent reflex. In myopathy, you'll have a preserved reflex. And in myopathy also, like you'll have like a proximal muscle weakness rather than a distal muscle weakness. So we did a workup, like ESR was like slightly elevated, was 48, CRP was like 3.8, hemoglobin A1C was like 5.0, thyroid functions are within normal limits, HIV was non-reactive, vitamin B12 was 567, and B6 was 9.6, SSA and SSB was negative, anti-gliadin antibody was negative. So these findings are highly supportive of like chronic inflammatory demyelinating polyneuropathy, otherwise called as CIDP. So CIDP is another version of AIDP, which is called Guillain-Barré syndrome, if the symptom lasts more than 12 weeks. And the treatment varies actually. And so we went and did a LP. LP showed like a cell count of 9 with a protein of 503. And technically, what they say was, if you have a diagnosis of CIDP, you can confirm with either electrodiagnostically or clinically, or based upon the LP findings. LP findings that if the protein is elevated like greater than 1 gram per kg, then it is supportive of CIDP diagnosis. And CIDP was first defined by Peter Dick in 1975. This is based upon just on the clinical evaluation. There is no electrodiagnostic criteria actually. Progressive, stepwise, recurrent pattern of the weakness greater than 6 months, but current definition is greater than 2 months. That's why he fit this diagnostic criteria. It usually symmetric, proximal, and distal weakness. And sensory symptoms are supportive actually. You don't have to have a sensory symptoms. Needs to have an elevated protein on CSF, which he has. Conduction velocity may be normal or maybe slow. Epidemiology wise, like 2 per 100,000, incidences like 1.6 per 100,000, peak incidences like around 5 to 6 the decade, which he is. Presentation, as I said, like they'll have a proximal and distal muscle weakness, but he has only like distal muscle weakness. I believe like the symptoms are started very recently, and large fiber sensory loss, which he has, like vibration is gone, and pinprick also reduced, and hyporeflexia or areflexia, and cytoalbinogenic dissociation, and nerve conduction study shows demyelination. So there are some variants, like we don't want to go into that detail. And this presentation, we call it as a classical presentation. And if you ask me like how common it is, like it's almost like 50%. And these are all the diagnostic workup which normally recommended on a patient with classical form of CIDP, which we did on this patient actually. Treatment wise, working with the therapy, and it is a collaboration with the physician, physical therapy, occupational therapy, and help with the gait and improving the quality of the life. Primary therapies are like IVIG, subcutaneous IVIG, plasma exchange, and prednisone. So for this patient, like we could not get a nerve conduction study during the hospital stay. So we empirically treated this patient with the IV steroids. We gave him for 1 gram for 3 days, and then like every week for next 4 weeks. And with 2 doses of steroid, he had a significant improvement with the weakness, and he's able to hold a cup with his hand. I think his diagnosis is most likely secondary to CIDP, the weakness. And other thing, we cannot give IVIG on this patient because he has a NSTEMI. So the only option we have is right now either treat him with plasma exchange or prednisone in long term. Any questions?
Transverse myelitis, can it occur in multiple pore levels, or is it usually a continuous lesion?
So it won't skip the lesion. So if it has last more than 2 levels, then you call it as LETM, long extensive transverse myelitis. But it can affect the entire SCOD. Thank you. Do you have time?
Oh, yeah.
I just want to review this image actually. They're talking about it was like venous sinus thrombosis. The mRNA is 0364.
I talked to Jody. I talked to Dr. Porter.
Okay.
This was there.
Okay.
You want to see it?
Yeah.
What's
I
the
don't know.
last-
I
what's the
just
last
saw
name?
his
Or
name
was
was
the-
Harmick.
Yeah. So. Wait, turn this off for a second.